with an indwelling catheters. There's different kinds of catheters, and we talked about them in nurse assistant class. When a person is unable to urinate for whatever reason, the bladder gets distended or gets full, and it has to be drained. You can't be, with your bladder filling and filling, and you're going to feel very uncomfortable. You're going to have pain. So that bladder has to be drained as soon as possible. Your bladder can only hold about 2 liters of liquid at one point. After that, you're going to be in severe pain, and you might incur more complications. So today's lecture on chapter 4 about advanced urinary skills. As a nursing assistant, you don't have the skills to insert or remove indwelling catheters. Your job is limited to managing the urinary catheter, such as catheter care, performing catheter care, making sure that the bag, is not on the floor, that it's not kinked, that it is draining, and so on. But as a patient care, you are also responsible to insert or remove indwelling catheters, which is actually a it's pretty simple procedure. But again, it goes back to sterility. You have to use sterile equipment, and you have to maintain sterile technique during the procedure. So you're going to be performing this on Friday. Okay, so please watch the video before you come in so that you can have a good idea. I'm going to explain to you the way the equipment is and how it stays in there and why it's done this way. Right. So yesterday I had a resident who never really complains of much. Never complains of much. So yesterday when he told me that he could not urinate, I took it seriously because he's not one to complain for anything. And he is alert, he's confused, but he can still tell you his needs. All right. So he tells me he can urinate. So I have to call the physician. Well, first of all, I have to do my assessment. So I usually go down here, right below the umbilicus, right around this area, and around right above the suprapubic area, where the hairline is right here. If you palpate down here, okay, a little bit lower, then you're gonna feel like a little ball, right? If you were drinking water or drinking a lot of fluids, that bladder is going to fill up quickly. Okay, your kidneys are going to produce urine, remove that excess fluid from your body, all right, and it's going to produce urine. So the urine comes down into your bladder and it's going to stay there until you feel the urge to go to the restroom. So if you palpate down here, which I did on this person, I could feel the little ball, okay, and I could actually see his lower abdomen was distended, okay, and it was very tender. So when I asked him, what do you feel? He says, I feel like I need to pee, right? So put a little pressure in, like it wants to come out. Now this person is incontinent, meaning that he cannot, hold his urine. He usually wears an adult brief. He goes on his adult brief, and we have to change him. He requires perineal care, very often. So when he told me he couldn't pee, and I felt his bladder distended, I had to do something about it. Okay, so another thing that was telling me that he was in pain or uncomfortable was the fact that his blood pressure was like 200 over 100, which is very high, and he usually does not run that high. So I knew something was wrong. I called the physician. I told him what was going on, and I did tell my CNAs. I asked them, to watch him, go check him to see if he's urinated or if he had a bowel movement, and so on. So maybe about 30 minutes later, the CNAs told me that he was completely wet. He had a large bowel movement, and he did urinate on his all over the bed pretty much. He urinated a lot. So it tells me that he couldn't urinate at one point. Now, was I going to continue with the catheterization on him? Well, yes, I had to continue. Number one, because the doctor did order the insertion of an indwelling catheter. Now, in CNA, we talked about intermittent catheterization. Intermittent means it's you go in, you insert the catheter, and you drain the bladder, and then we take out the catheter, and then that's it. That's the end of that. But in this case, I had to insert a catheter that's going to stay in the bladder. It's called indwelling catheter. All right, an indwelling catheter can stay there temporarily, a few days, a weeks, or sometimes even permanently. Okay. However, these have to be changed on a regular basis. The standard of care as far as catheters are concerned is every 30 days. They need to be changed every 30 days unless the doctor recommends, more often than that, maybe every 2 weeks or so. But we don't recommending it, changing it too often because the risk of introducing infection into the bladder increases as we mess around with it more. So it's better just to do it, every 30 days or so. So the catheters themselves, they're made out of rubber, okay? They're made out of rubber, okay, you can see. So we have to ask for allergies, okay, to latex. A lot of these are latex free now, but we still ask, all right? Now, it's not one size fits all. There's different sizes. They come in, just like the needles have gauges, these come in sizes, but they call French, okay? French is the size. For example, this one is a 16. If you look really, really closely, I don't know if you can see the letters there, okay? It says 16 French, okay? 16 French is the girth or thickness. There's 18, 20, 22, 24. They come in even numbers, okay? Whatever the doctor prescribed is what we place in there, okay? In this case, the doctor didn't specify a measurement, so I pretty much went with the standard, which is, 18. 16 is kind of the standard, like everybody does 16, but I went ahead and did an 18 catheter, 18 French catheter on this person. Now, this is the part that's going to go into the bladder. Okay, so let's say this is the bladder. Okay, so we insert it through, and if it's a male, okay, we have to hold the penis, right? And I'll go through the whole procedure in a bit, but it goes in through the meatus, which is the opening of the penis, okay, or the female, same thing, the meatus. It goes in here and then makes way itself into the bladder. Okay, so now over here, it's already in the bladder. Okay, and once it goes in there, urine automatically starts coming out. Why? Because in the anatomy, the urethra, we have some valves. Okay, we call them sphincters. Sphincters. We bypass those sphincters like a door, like a little door, right? Like if you hold your urine, that sphincter is like a muscle, and it closes, and it helps you keep that urine inside your bladder. But once those sphincters become weak, they weaken, especially if you have large babies or have multiple babies. Those muscles can actually help, will weaken, and what's going to happen is that you might have incontinence, cause stress incontinence, right? If you cough, yes, you will be doing that on Friday, okay? Now, there's a little caveat, right? A little catch. If you work in a facility, okay, and you know how to do this, okay, and you have good relationship with the nurse, and I know that you are a good patient care, you're very knowledgeable. I will tell you, okay, I can delegate that to you if it's in your scope of practice, and if the facility policy also allows it. I can tell you, you know what, Erica, go ahead and place a Foley on such patient, and I'll tell you the size and what kind of catheter is going to be indwelling, like this one, or is it going to be an intermittent kind of catheter? It just depends. It's just the condition of the patient. So again, I have to think like, okay, can Erica do this patient? Like there's patients that have a condition called BPH, or benign prostatic hyperplasia, and their prostate, which is a little gland on the males, females don't have prostates. It's a little gland about this big, like a grape. It's underneath the urethra. Okay, I think there's a picture of the anatomy here. Hold on. So you can get an idea of what I'm talking about. Where's the PowerPoint? Oh, there it is. So the prostate is right underneath the urethra, and when it gets bigger, the urethra gets bigger. The prostate enlarges. It puts pressure on the urethra, so urine can't come out. All right, the urine cannot come out. So what happens is that you will be unable to insert the catheter. It's going to be very difficult. Okay, so if I know that I have a patient that has this problem, I'm probably not going to ask you to do something like this because uh, it would be challenging for you. Okay, and you're not going to be doing it, and you might actually hurt someone. Okay, so I would not ask you to do something that I know that you may not be able to do. So, so you have to be a little familiar with the anatomy of the the body, the males and the females, so that you can understand more or less where. Let me see if I can make this bigger. Let's try to make this bigger. Okay, y'all see the picture, right? Can you see it, Norma?
Yes.
Right here? Okay. I can't see very well if it's a male, female, but regardless, male, female, the anatomy is similar. The only difference is the prostate in the males. But the catheter, this is called the straight catheter because it just goes in and then you will take it out. Okay, we just want to drain that bladder. I do have a resident who has what we call neurogenic bladder. Neurogenic bladder means that the nerve that stimulates your bladder to contract and empty itself, that nerve doesn't work anymore. So the bladder will never empty itself. So what do we have to do? We have to go in there and catheterize him. We just say cath because it's easier. We go in there and cath him or her, right? And empty that bladder. That's a straight catheter, or we call it also in and out catheters. And then we do the indwelling catheters, which is just like the one I'm showing you right now, okay? And those are meant to stay in there for undetermined amount of time. Now, usually when we insert a catheter and indwelling, we're gonna be doing collecting a urine specimen, all right, for urinalysis and for culture and sensitivity, which we talked about in phlebotomy as well. So you may be collecting a specimen like this, which I had to do yesterday. So again, straight catheters, and then there's indwelling catheters, and then the other one, it's the same thing. It's the same thing with catheter, except the opening where you're going to insert the catheter is actually right above the pelvic area. Supra means above the pubic area, which is the pubic hair. Right above that, the urologist can make a little stoma, a little opening into the bladder. Okay, so the person is lying flat on the bed, and you're gonna see the little opening, and the catheter goes straight down into the bladder, and then you're gonna see urine coming out. All right, you see urine coming out, that means that you are in the bladder. Okay, so instead of going through the penis or the female urethra, right, you're going up to the abdomen wall. Okay, you're gonna see this. I have a couple of patients that have that, but and in some facilities, you'll be allowed to do suprapubic. Some places do not allow you to do suprapubic catheters. They're mainly left those for the registered nurses. But now, what's in the catheter? How does it work? How does it stay? Okay, inside the body. Well, if you look at a picture, let's see. I think there's a slide in the next one. Let's see. There's a picture of it. I was trying to look for a picture, but in the book you see the picture, okay, of the a sketch of the catheter, okay. So in the very tip of the catheter, there's a balloon, but you can't see it yet because it's not inflated, right? So we insert it like this, uninflated, obviously. But before we inflate we before we insert the catheter, we want to test the balloon, make sure it's not torn or broken or malfunctioning. So we always test it, and we do this by inserting water, right? That comes in the kit. Okay, stir water, and y'all see that. You see that balloon? Well, usually there's a predetermined amount of water that you can put in here, and it tells you in the catheter on this side, on this point. It tells you the amount of water you need to put in there, and it also gives you the size of the catheter. In this case, this is an 18 French, and it tells you 5 cc. Cc stands for cubic centimeters, which is the same thing as milliliters. Okay, cubic centimeters and milliliter are exactly the same thing. So this is a 5 ml syringe. So I would have to inject 5 ml of water in the balloon so the balloon can stay in there. So once it makes it into the bladder, we inflate the balloon, and that way the catheter cannot slip out. All right. Your body automatically wants to push it out, right? So we keep it in there by inflating the balloon, making sure that it does not slip out. All right. And that's how these stay in there. So once it's in the bladder, you bypass your sphincters. Okay. The urine starts draining through this tip. Okay. To the big one. Now this one will start draining. Once it starts draining, then we inflate the balloon. Okay, so we put it in, we see urine come out, we push it a little bit more, and then we inflate the balloon. And then we have to connect the catheter to the collection bag. All right, this is the collection bag. I'm pretty sure you've seen some of these. Or if you had kids, you probably already have one in you. The collection bag. This is the one where you collects the urine and you drain it out and all that. So you'll be learning how to insert the catheters on Friday. So please make sure to come by and watch the videos before you come. That way you have a good understanding of what you're doing. So again, reasons for catheterization. If you're going to have surgery, we don't want you to be going, urinating all over the sterile area, right? So you're going to need a catheter. The person cannot void, like I just told you, they're going to need a catheter. The urethra is blocked for some reason, right? Because of the prostate gland, which I just mentioned earlier. That's another reason to catheterize someone. If the doctors want to keep an eye on the amount of urine that the person is producing, maybe they're starting to have some kidney failure and they want to monitor the amount of urine that they're producing, we can insert a catheter, right? Like for strict input and output measurements, we can insert a catheter. If we need to collect a sterile specimen for urine to analyze it for urinalysis in CNS, we can do a straight, in and out catheterization. We can do that also. When this person has wounds, like pressure ulcers, like the ones you saw yesterday, and urine is always, the person is always urinating and it's affecting the wound healing, it's, infecting it and it's slowing it down, it's making it worse, we can certainly insert a catheter to prevent that from getting worse. So there's many reasons for a person to have a catheter, and these are some. Now, the risk that come with inserting catheter is, of course, infection. Okay. Now, why does a person have a risk of infection? Well, the catheter itself, okay, even though it's inside the body, it's not fixed. It's not like it doesn't stay there completely. So let's say this is the bladder, it's already in there, but the catheter itself still travels in and out. When a person turns on their side, they pull on this, so this catheter moves in and out. So bacteria that is outside here can go in and out, in and out. And this is why we perform catheter care on patients that have an indwelling catheter. All right. So it's very important that we perform catheter care to prevent the risk of infection going in there. Urinary tract infection, again, from the hospital or HAIs, healthcare associated infections happen a lot. Urethral trauma. Sometimes if you're not careful and you turn a resident and forget to turn the bag first, you tug on it and the urethra may be very sensitive. They may start bleeding. So you may see a little bit of blood coming out. Don't panic. Usually it stops by itself. A few weeks ago, there was a resident who was confused. He thought he wanted to go home and he had a catheter in him, all right? And he just decided to yank it out. He pulled it out and it was a bloody mess. It looked like a crime scene there, like a murder scene. There was blood all over the place, all right? Now, the bleeding did stop eventually. However, this person needs to be evaluated a little bit more because some blood clots can form in the bladder and they're going to obstruct the urethra. So that's a problem. Okay, so again, urethral trauma can happen. As a matter of fact, there's many other problems that can happen, but the most common ones, of course, UTIs and urethral trauma. Before we insert the catheter, we definitely need a doctor's order. We can't just put it in there because the patient wants it or because we think it's a convenience for us so they don't have to be changing them all the time. We cannot do that, all right? We have to get a doctor's order. When you're going to insert it in a female, the best position to put him in a female is on their back. Of course, the supine position is going to open her legs and slightly bend, right, to give way or access to the genital area. Okay, now sometimes some patients are contracted. You know, their legs are contracted in this way, where it's impossible to open the legs to insert it in this way. So one of the easier ways to do it for patients that are contracted with their legs up like this is to turn them on their side, okay? And you can have easier access to the genitalia through the back side, okay? It's not the best, easiest way. It may not be the perfect way to do it, but it is possible to do it that way. Now, from personal experience, the most challenging ones that I have trouble with inserting patients is the ones that have a lot of, they're a little bit on the heavy side. It's very difficult for them. I just had a resident about 2 months ago. She needed her catheter to be changed out. I said, no sweat, I've been doing this for many years. I'm going to go in there and change it out. Well, it wasn't that easy. This is a large lady. She's tall and on the heavy side. That wasn't the problem so much. The problem was that she can't really move her legs, and her legs weigh like 50 pounds each, right? And so I asked her to, bend her legs, and then she's lying on a bed where she's sunken in. So her bottom was sunken in, but her legs were up. It was very difficult. And of course, I could not insert the catheter. If I did insert it, I probably didn't get it in the right place. Why? Because it didn't get urine output. So I felt, in 20 years, I've never really felt inserting catheters was very easy. But this lady really gave me a hard time. But, it comes to practice. On males, the only challenge that you have with males is that if the male has a very small penis,
Sure.
yes,
I have a question. So when you're putting the catheter, you have to get urine back out or you're not in the right place.
correct. Once you see urine come out, you want to push it a little bit more, and then you want to inflate the balloon so it doesn't slip out. Now, you don't want to go too far in. You don't want to go too far. Why? Because you might actually go up into the ureters, okay? The ones that bring the urine from the kidneys. You don't want to go in there because you might inflate the balloon up there and you might cause trauma to the ureters, okay? So you got to be careful. Again, on males, the most challenging is really when they have a very small penis and then they're a little bit, on the heavy side. The penis will sink into the fat, the adipose that we have here in the suprapubic area. So you have to press down on that, that little fat part so the penis can come up, and you have to hold it and insert the catheter in there. But other than that, of course, it's much easier. There are some patients that after having catheters for too long and they tug on them, they pull on them a lot, they actually start to get what we call meatal tears. The meatus, the opening in the male, starts to tear and it starts to come down in this way. It looks pretty nasty, but that's another complication. Tell whether the following statement is true or false. You do not need a doctor's order to catheterize a patient. Of course, that's false. You cannot do any invasive procedures without the physician's order, okay? Please make sure you have a doctor's order before you insert the catheter. And there's that picture that I was trying to show you earlier, okay? You see the way it's inserted in there into the bladder. You can see this little part right here. This is the prostate, okay? And this is the urethra, okay? Where the urine comes out. Well, it's over the prostate. So if this enlarges, it pushes the urethra and it squeezes it, and the male cannot urinate. It becomes very, very difficult. And this is a very common problem in males, okay? Benign prostatic hyperplasia or enlargement of the prostate. And then some people can develop cancers. There can be a serious condition. And you can tell when a male has BPH because they start to urinate more frequently, more often. They go to the restroom a lot more often than normal, right? They drink like just 1 cup of water, and then they have to go to the restroom. They have to be emptying their bladder very often. That could be a sign of benign prostatic hyperplasia or BPH. So the indwelling catheter, which is this one, okay, it's a closed system, meaning we cannot be opening, disconnecting this from here at our convenience, okay, because you have a high risk of introducing infection. So once it goes to the urinary meatus, which is a little opening right on the outside, on the females, we can see the meatus. If the female pushes a little bit, okay, like you bear down, you push a little bit, the meatus will open up. It kind of blinks like it's blinking. We do that. If you can't see it, then ask you to push, and it opens up, and now you know where it is. So now you know where to insert the catheter. On the males, obviously, it's right there. You can't miss it. Okay. The length of the tubing connects the catheter to the urine bag, which I already showed you. And disconnecting the catheter. If you have to disconnect it, usually we only disconnect it for a couple of reasons. Number one is when the person is going out, maybe to an event or to appointment, they don't want to carry around this huge old bag, right? Well, we have something called the leg bag. Some people call it a Texas bag for some reason, because it's like it goes on the leg, you tie it down to the leg, and it can catch urine. It doesn't hold as much as this one, obviously. It only holds about 1 liter of urine. So it has to be drained out. So the person can go to the restroom and drain it out and, go about the business. So that is one of the few reasons why we actually disconnect it. Okay. Other than that, we don't disconnect the catheters. Which catheter is inserted in the abdomen to drain urine? Somebody tell me the answer or type the answer. Which catheter is inserted in the abdomen to drain urine? It's called the suprapubic catheter. Again, supra means above, pubic, it's in the pubic area. So above the pubic area, that is where that catheter is inserted. Collecting a sterile urine specimen. So once you connect or insert your catheter, your indwelling catheter, or even the in and out catheters, right? Once you insert it, usually you'll have your specimen cup ready to go right there, where you're going to get your specimen. Okay. All right. The catheter tubing is clamped down. The aspiration of the urine collects in the tubing. Now, sometimes you'll need to collect a specimen on a patient that already has the catheter in them. Okay, you're not going to be doing it the first time they already have it in them, and the nurse will ask you, well, can you collect a specimen, a urine specimen for him? So a lot of times, some people will disconnect it and get it from here. That's not the way you do it. Okay, you may introduce infection. What you have to do is that on the collection bag, on this bag, okay, you're gonna see a rubber port, like a little circle right here. Okay, you're gonna either you screw in a syringe, something like a regular syringe, and you screw it on here, and you aspirate the urine out of the catheter. However, before you do that, you have to kink. You have to kink the tubing, okay? You have to bend it so the urine stays in the bladder, okay? So here you come along with your syringe, and you either have a needle on it and you poke it and you aspirate it, or you screw it on here and you aspirate it, okay? But the urine is coming from the bladder, okay? Never collect a urine specimen from the bag, okay? You should not be collecting urine specimens for the lab, right? For urinalysis or CNS from the bag. That's just a big, big no-no, okay? The urine has to come from the bladder. And that is how you collect a specimen, urine specimen, when a patient has a catheter. Once in a while, you'll run into patients that have irrigation, types of irrigation. Now, why would you ever have irrigation? And to the bladder, because some of the patients that I mentioned earlier that have prostate enlargement, they undergo a procedure called TURP. Okay, you can Google this and look it up if you want to learn what it is. It's a transurethral resection of the prostate. It's a procedure that is done sometimes in the doctor's office, sometimes in the hospital, to get that prostate to shrink, to make it smaller, right? Of course, there's going to be trauma, so there's going to be bleeding. So if there's bleeding inside the bladder, you're going to have blood clots. And these blood clots, they're going to get stuck in the urethra. So to prevent, right, blood clots from forming and to speed up the recovery of the bladder, we perform irrigation. Remember we said irrigation is putting water or normal saline or some kind of cleansing agent into a wound. In this case, we're inserting the irrigation into the bladder. So it's going to be continuously washing the bladder, okay? So those catheters, we call them a three-way or three-port catheters. These catheters are, again, only used for irrigation. Now, sometimes patients will have their catheter clogged, okay? The patients will start urinating and the urine will come outside. It'll start, coming out of the bladder. And you're like, why is a patient getting wet when he has a catheter? Well, it's mainly because when it's time to change out the catheter, the bladder starts to spasm. Okay, they get spasms and the urine leaks around the catheter and into the bed. That's what happens. Or sometimes the catheter itself is plugged, the little ports that are right here. You can see it. There you go. You can see it. Those little ports, okay, they get clogged with residue, okay, sediment that is inside the bladder, and then the urine can't come out, right? So it'll come in here and then it'll get stuck in there. So what we have to do is we do open irrigation. We get a big syringe like the one you see in the picture, okay, and we get a sterile saline, okay, or sterile water, and we inject it through the big port, disconnect it, inject it, and push some of that sediment out, and hopefully it'll clear it up, and then the urine can start coming out again. It happens, especially for the residents that don't drink much water. A lot of sediment forms inside the bladder, and it clogs the catheters. Closed irrigation, we don't do it very much because it's very difficult. But here's pretty much an example of how we collect the specimens I was telling you earlier. We have to clamp it right here so the urine stays in the bladder. So this is in the bladder. Okay. I'm sorry, it's this way. Catheter tubing is this way. This is where we get our urine samples from. Okay. Oops. There you go. And this is a triple lumen catheter that we use to irrigate the bladder. So we hang up big old bags of normal saline and we connect it to the tubing, which is a three-way catheter. Here it is connected here. And the water goes in and it irrigates and then it comes out through another port and into the bag. Again, this is normally used for patients that had surgery in the prostate surgery. Okay, we used to do it a lot. I don't think it's done too much anymore. I don't see patients having this procedure done too often. I think there's better procedures that don't cause that much trauma. Which irrigation is often used after prostate surgery? Well, this is the continuous irrigation. Continuous irrigation. This is what we do. It's usually done for at least a day. It's a hassle. You have to be going in there in and out, and you have to calibrate the flow, make sure it's irrigating the bladder so that clots don't form. It's really, really tedious and very time consuming. All right. So again, this is a sterile procedure. Okay, so you have to know how to perform sterile technique before you perform insertion of an indwelling catheter. How do you know when a person has an infection? Well, usually you will see the urine, it becomes very cloudy, very strong foul smell. You may even see a little bit of blood in the urine. It's called hematuria. Hema is blood, urea is urine. Hematuria refers to blood in the urine. It could be pinkish, or it could be red, or it could be even blood clots in there. when somebody has, blood in the urine, most likely they do have a UTI. Okay, so cloudy urine, strong smelling urine, and some blood in it will definitely, those are the signs of a UTI. In the book, you'll find some pictures, illustrations on how to perform the procedure on a male and a female. Okay, so we're all adults, so we're gonna handle this as adults. We have mannequins. You'll be performing the insertion of indwelling catheter on a female or a male, depending. So we have a few things to do on Friday, guys. Make sure you watch the videos that you feel comfortable doing the sterile field and also the sterile insertion of an indwelling catheter. All right. Does anyone have any questions at this point?
No.
No? Norma, Janie, Miss Erica, I know I can't hear you, but tienen muchas preguntas. Okay. Yeah, you can text them or Friday when you're here, but for sure, make sure you watch the videos. That way you have a decent idea of what we're going to be doing. Um, but for sure, we'll do that on Friday. All right. Yes, on Friday and morning. Make sure you guys make plans. All right. Make arrangements to be here on Friday morning. We'll be here at least from 8 to 10. May go a little long depending how fast you all perform the procedures, and I watch you do it correctly. So that's why I want you to watch the videos before you show up, so you have a good idea, and it'll be a little faster for you guys if you need, if you need to